Good morning. Thank you for the opportunity to present at this press conference to tell you about our study. I have nothing to declare. Now, in the PURE study, it's a large program where we were interested broadly in risk factors for cardiovascular disease, the causes of these risk factors, and the influence of these risk factors on cardiovascular disease. So it's a big project, and in this particular analysis or presentation, we look at the risk factor burden and the incidence of cardiovascular disease and death associated with the disease. So why did we do this study? Well, 80% of the global burden of cardiovascular disease occurs in middle and low-income countries. We think that rich countries always have this high disease, but actually more people die or have the disease in the middle and low-income countries. Why is it so? Is it because 85% of the population lives in these countries, and with similar incidence and mortality, we have the same proportion of disease, but we don't know. This may be a higher risk factor burden and incidence in these countries, in these middle and low-income countries. There may be a higher case fatality in these countries too. So, and then another point, with urbanization rapidly increasing in these countries, is the risk factor burden higher in urban than rural countries because people move from simpler lifestyle to more complicated lifestyle? Is the cardiovascular disease incidence mortality higher too in the urban versus rural areas? So we started this study about 10 years ago, and we have now recruited 155,000 people from 628 communities in 17 countries from 5 continents across the world. These countries were of varying economic development, from low-income countries to high-income countries like Canada and Sweden to low-income countries, India, Pakistan, and Zimbabwe. So they're all in between. So we want to look at the spectrum of countries and see how they perform. We have recruited them, and now we're following them for up to about 4 years. And the reports here are the incidents during the last 4 years. So to share with you the results, we found that the risk score, there's a risk burden as determined by the Interheart risk score that we derived and published, that the risk burden were highest in the high-income countries, intermediate and middle-income countries, and lowest in low-income countries. And also that the risk burden in the high-income countries was slightly higher in the high-income countries, but they were lower in the middle and lower-income countries. So there's some contrast there. Next, how did these risk factors translate into cardiovascular disease? And here we look at the risk burden was highest in high-income countries, but you will look, the incidence of major cardiovascular disease was highest in low-income countries and lowest in high-income countries. So it's reverse. Rather than low, you would expect with low risk burden, there'll be lower disease, but it was reverse. And fatal CVD, the case fatality was even more striking. And then other cardiovascular disease also showed the reverse, then, that there were other cardiovascular disease which is reflected by hospitalizations. We have more hospitalizations in high-income countries, and they came that way: angina, unstable angina, mild heart failure, and so on. So if you add up all together, then the incidence of cardiovascular disease in these 3 groups countries are more or less similar because of the differences in the patterns, but are more or less similar. Now, if you look at the annualized case fatality rates, that is, for the various specific diseases, MI, stroke, heart failure, major cardiovascular disease, and total cardiovascular disease, you can see that consistently the low-income countries had much higher rates. There were higher fatality rates. More people died from the cardiovascular disease in these conditions. Intermediate was in the middle-income countries and lower in the high-income countries. Such that if you look at death from stroke or from MI or from heart failure, the deaths in those low-income countries were almost 3 to 4 times higher than that in high-income countries, despite the lower risk factor burden. So this is the one that really, in a way, surprised us, but at the same time we wonder what happened. So why is this the case? Well,
Dr. Koon, we're at 5 minutes, so we need to go to the concluding remarks.
Yes. Why it is so? The reason is probably because of the better risk factor control ameliorates the risk factor burden and better management of disease, reducing in lower deaths. But that means that in low and middle income countries, there has to be not just risk factor control, but also better management. And this is where we call the health systems has to be looked at. Thank you.
Well, thank you, Dr. Koon. This presentation is now open for questions. Can you raise your hand and we'll come to a microphone? Can you please come to a microphone, please? We have the microphones. Please give your name and organization.
Steve Stiles with theheart.org. I'm wondering if you could talk about what factors you may have controlled for in the analysis to sort of help tease out the other perhaps related factors that may be accounting for the differences.
Sure. We control for age, obviously, control for sex, and we also control for, depending on what equation we look at, regions and other things. So we did control for those things and other. So of course, risk factors don't control because of the risk factors, but we control age and sex in general.
Did you control for aspects of the health care delivery system?
Well, that's where the question is. We're not sure what healthcare delivery system is. That's our next project. So that raises the question.
Dr. Teo, Bruce Jansen from Cardiology News. Could you talk a little about the health policy implications internationally of your findings?
We hope this is going to have a huge impact because we think that somehow the health system, delivery system in all the different countries, including ourselves, we think we're spending too much money. Are we spending this effectively? And that the lower income and middle income countries have to have some kind of system where these people are actually treated effectively, efficiently. In the low income countries cannot spend as much money as we do in the West, but looking at their history, better treatment of high blood pressure, better treatment of lipids, at the same time, efficient way. For example, maybe combination medication can help, or whatever it is that has to be built into the system.